I am Dr. Jayagumar from Aster Medicity, Cochin. Next half an hour, I am going to discuss some aspects of diabetes seen in children and adolescents. As you know, diabetes is a worldwide problem now, becoming a pandemic. It's a non-contagious disease, a non-communicable disease, which is becoming very epidemic to pandemic proportions. And as you know, India is one of the top leading countries with the maximum number of diabetic patients in the world. Now today, we will be discussing something about the diabetes you see in the childhood and adolescence. First of all, what is diabetes? Diabetes is a condition where there is absolute deficiency of insulin or defective action of insulin, so that the carbohydrate metabolism and other lipid metabolism and all altered, leading to hyperglycemia and symptoms and later on long-term complications. And the majority of diabetic patients are usually seen in adults, but nowadays we are seeing a good number of patients in the childhood and adolescent area also. As you know, when a disease like chronic disease like diabetes occurs in a child or an adolescent, not only the patient but the whole family is affected. They all have to take part in the diagnosis, management, day-to-day management, and physical, mental and financial support for the patient concerned. Now coming to the first aspect, what are the different types of diabetes which you can see in a childhood or adolescent? As you know, the good old days, when I was a medical student 45 years ago, when you say that diabetes in a child, it automatically means that it is type 1 diabetes or insulin requiring diabetes mellitus. But conditions have changed. Now even though the major, if you see diabetes in the youngsters and children, it may be, the majority may be type 1, but there is a good number of patients who come under the category of type 2 diabetes in the young. So if you look at the spectrum of diabetes seen in childhood and adolescence, about 50 to 60% will be contributed by type 1 diabetes, whereas about 30-35% will be contributed by type 2 diabetes, and the rest, a small percentage will be contributed by rare conditions which are due to genetic alteration or associated with genetic diseases. But we are going to focus mainly on type 1 diabetes and type 2 diabetes in the young, as the genetically associated diabetes will have a just passing mention, which are very few in number and very rare conditions which require only which an ordinary practicing physician may not be dealing much on it. Now coming to the type 1 diabetes, it is mainly an autoimmune disease. This is called type 1 autoimmune disease, means the body's autoimmune immunological system goes out of way and start attacking or destroying the beta cells of the pancreas. And as you know, this is usually due to development of antibodies against the body's pancreatic beta cells. And this destruction starts, and it's not a direct genetically transmitted disease from father to child, but there is a genetic or a background for this because of the HLA associations. Certain HLA associations like DR3 and DR4 systems have some loci which may attract an autoimmune destruction focusing on beta cells, and rarely there is a DRQ which may even protect the person from getting this. So whatever it is, there is an HLA association with this type 1 diabetes, which may be also brought by other things like initiation of the autoimmune process. It may be following an infection by a virus like a measles virus, mumps virus, Coxsackie virus. All can initiate the autoimmune process in a person. There are so many, the exact etiology of why some people get it, all the people with the HLA association need not get it, but why some people get it, there are so many theories. Even people have said that breastfed children the chance of getting this type 1 is much less compared to feeding by cow's milk and all, because some of the antigens present in the cow's milk may be antigenic to the fetus, and the child's immunological system may react to the antigen with production of immunological response and antibodies, which may go and destroy the beta cells or the pancreas. That is one theory. So there are so many theories, but nothing has been absolutely confirmed. But these are the theories. But the main thing is there is a HLA system allows a predisposition to getting the type 1 diabetes, which may be precipitated or accentuated by a environmental factor like a virus infection or a food or any allergic things. So this is about type 1 diabetes. Whereas if you look at type 2 diabetes, which is a disease due to insulin resistance, and which was usually commonly seen in people above the age of 30 plus. That was a usual thing. But during the 1990s onwards, it was noticed that even this so-called insulin resistant type 2 diabetes can occur in children also. It has been named as type 2 diabetes of young. So usually it occurs around the age of pubertal development age, that is around 12 to 14 years of age. By the time the immunological system get reactivated, and the insulin resistance may become manifest, along with the environmental factors like the dietary not following the diet, putting on weight, lack of exercise, psychological tension. All these may be contributing precipitating factors. And there the insulin resistance patients, usually there is a strong family history will be there. This one or both side parents may have the diabetes, type 2 diabetes, which the children may get it because of the local environmental factors. Now the third group is the rare group is due to genetic mediated diabetes due to alteration insulin production or insulin action. These are very minimal. The commonest one is what is called MODY, maturity onset diabetes in the young. Now it has been named as monogenic diabetes of the young. There are about 8 to 9 types due to alteration in genes, where the insulin sensing genes, insulin the transportation genes, all may be affected. And this usually there is a strong family history of this MODY. Both sides parents will be having at least 2 generations on both sides. There will be a strong family history, and they will not be usually very obese and all. So if you see a person with a strong family history of diabetes on both parents, maternal and paternal side, at least for 2 generations, and the patient is not very obese and getting diabetes, think about the possibility of MODY or maturity onset diabetes in the young, and send for the necessary investigations. Then you can get diabetes associated with genetic disorders like chromosomal disorders like Klinefelter's disease, like Turner syndrome. It can be associated with Down syndrome. These are all rare conditions, and we don't want to spend a lot of discussion on these things. So we will be focusing mainly on the type 1 diabetes, the children, and type 2 diabetes, the young, which is also seen here. Now coming to the clinical presentation of type 1 diabetes. Type 1 diabetes is usually, there is no, the parental family, father and mother may not have a history of diabetes. There may be a history of type 1 diabetes, around 10% in the family of type 1 diabetes history may be present. And usually they come with severe symptoms because it is absolute insulin deficiency. So they will come with severe osmotic symptoms like polyuria, polydipsia, dehydration, and some of the infection may be precipitating this acute episode. So they usually come with severe metabolic, that is osmotic symptoms like polyuria, polydipsia, weight loss, eating well and losing weight. Then they will go into what is called diabetic ketoacidosis. When the insulin shortage is there, cannot utilize the glucose properly, they will the metabolism may shift to the fatty acid cycle and the ketone bodies production and all those things, and it will so the patient will become very ill and sick, and they will usually come with acute, and they will land in an emergency of the hospital with a severe nausea, vomiting, dehydration, low BP, altered conscious level, and the duty doctor will be able to make a diagnosis on the basis of raised blood sugars and raised usually ketone bodies will be present. Now, so these will be thin, not very thin. They may be usually the usual teaching was that these people are not obese, type 1 diabetes in the not obese. But nowadays, during the last 2 or 3 decades, because the obesity, childhood obesity has increased to a considerable extent, there can be even obese children with type 1 diabetes, but the obesity percentage of type 1 diabetes may be similar to the percentage of obesity in the childhood there in the seen in the community. I will say around 10%, less than 10% of the type 1 diabetes may be overweight or obese, whereas 90% will be normal weight or underweight. Now coming to the type 2 diabetes of the young, usually they present very slowly. They may be usually picked up in a medical checkup, or they would have gone for just an acute illness and went to the hospital, and routine checkup will show a blood sugar or urine sugar. The chances are that a small percentage can also present with severe infection, and they also can go into ketoacidosis. But the chance of patients type 2 diabetes, the young, presenting with the ketoacidosis is around only 10% or 15%, whereas in type 1 diabetes 90% may present with ketoacidosis. That is one difference. Second thing is, most of the patients with the type 2 diabetes young are obese, and if you look carefully and do a good physical examination, you will be able to see the signs of insulin resistance like acanthosis nigricans, that is a brownish to blackish pigmentation, all the flexors, the back of the neck, axilla, groin, and all those things. And they may see some tags, skin tags also may be sometimes seen. And this is the thing, obese. And if you take a family history, there will be a family history of diabetes in the either, or at least in one of the family, either in the maternal or paternal side, or both sides it may be there. And usually they come with vague symptoms, and it is picked up in a routine medical checkup for other illness, and rarely they can also present with ketoacidosis and may require inpatient care, intensive care treatment. Now this is the presentation style of both this type 1 and type 2 diabetes young. Now you come, how are you going to confirm the diagnosis of, because confirmation of diabetes type is very important in this, because the treatment depends upon whether it is type 1 or type 2 diabetes. So in the acute phase, when both these cases come with the ketoacidosis, usually they are treated in the intensive care with the usual treatment protocol for diabetic ketoacidosis. But the physician has to make a decision whether you are dealing with in the further management of the case, whether you are dealing with a patient of type 1 diabetes or type 2 diabetes at the young. Even though there are some guidelines, you can make some investigations and make a diagnosis, 100% is not possible. For example, if the patient, if you suspect clinically non-obese, presenting with ketoacidosis without family history of diabetes, you may think it is type 1, and you may be able to confirm it by doing antibodies. Especially there are so many antibodies available for diagnosing a case of type 1 diabetes, but none is 100% proof. The maximum used is antibody to GAD65 is the one which is usually done and which is usually positive. It may persist for a longer period of time. The other antibodies which can be done is IA2 antibodies, insulin protein antibodies. Then you can have islet cell antibodies, you can have insulin antibodies. So the more number of antibodies you do, the chance of making a diagnosis confirmation is more. So the common one which is usually done in all the usual hospitals are GAD65 antibodies, and IA2 or islet cell antibody are done. The other thing which you can do is to measure the C-peptide level. That is, there is a marker of endogenous insulin production. But the problem is that in the acute phase of when the patient presenting type 1 patient present with the ketoacidosis, the pancreas and the whole body is under glucotoxicity, and whatever little beta cells they will not be able to work. So if you are going to look at the insulin secreting capacity of a patient suspect of type 1 diabetes, then I must say that you must wait for some time till diabetes is properly controlled, the glucotoxicity is removed, and the beta cells gain back to the status, so that you will may be able to assess the beta cell status properly by measuring a C-peptide. Whereas in that type 2 diabetes for confirmation, it is mainly family history, clinical presentation. There is, and if you do a insulin or a C-peptide, it will be slightly above normal because of the insulin resistance. It may be within normal range or is above normal, but that is not a must to make a diagnosis. More of a clinical diagnosis and follow up and seeing that the patient can be treated or managed without insulin is the one. That other points which you have to remember is that type 1 diabetes require lifelong insulin therapy, and if you are not giving a patient insulin in a type 1 patient, within a week time the patient will land with uncontrolled diabetes and leading to ketoacidosis. Whereas type 2 diabetes, if the patient, even if does not give insulin on OHS or diet restriction, they may pull on even with a little hyperglycemia. So that is the other thing. On follow-up, if the patient is not getting during the last few months, never even off insulin, not getting a single episode of ketoacidosis, the chances are that the patient you are dealing is a type 2 diabetes young. Whereas within a week or a 2 weeks time, a patient of type 1 diabetes patient, if or not given insulin, off insulin for a few weeks time, the patient will land with ketoacidosis. Now, having said about confirmation by doing the investigations, and you may have to, suppose you are suspecting rare condition like MODY, you can send the genetic studies for MODYs, which are now available freely all over India. You can get it done and you may be able to confirm it. Then now coming to the management aspects. So management of type 1 diabetes is entirely different from management of type 2 diabetes. So type 1 diabetes patients require lifelong insulin therapy, but the amount of insulin and the frequency of insulin therapy may be little altered depending upon the residual insulin secreting capacity of that given patient. Usually the classical treatment for type 1 diabetes is giving basal bolus therapy, that is giving a short acting insulin with each meal and a bedtime insulin, long acting insulin analog at bedtime, so to cover the the nocturnal hepatic gluconeogenesis and all those things. So the classical the best treatment pattern is basal bolus therapy, that is basal short acting insulin with each meal and a basal insulin at bedtime. But see that takes 3 or 4 injections, but a number of good number of patients in the of type 1 diabetes may be controlled with the 2 shots of mixture of short acting plus a long acting insulin. For example, short acting insulin along with a long acting NPH given in the morning, plus that is 2/3 long acting and 1/3 short acting. Then the same the 50-50 of short acting and long acting at night before the in. A good number of patients may be managed reasonably for a short period of time or some time, so that only 2 shots are there. But majority will require in the long run 3+1, that is 3 short acting with a basal insulin night. How much insulin to start with? Usually they require about 0.1 unit per kilogram body weight in 24 hours usually, but patient with insulin resistance or with a little overweight may require up to 1 to 2.15 units per kilogram body weight. The type 1 diabetes usually has 2 peaks. One peak is between 5 to 7 years and the second peak is around the pubertal time, about 12 to 14 or 15 years. And if you see somebody with type 1 diabetes before 4 or 5 years time, some of them they may be managed with a long acting insulin acting 24 hours at 12 hours, 1 shot or 2 shot of a short long acting insulin like Glargine. You may be able to control a type 1 diabetes in the age of 3 and 4 years old. They may be remember, treating type 1 diabetes in the children is a very difficult one, because even giving the usual teaching is you have to give short acting before meals, but in a child you don't know how the child is going to eat, and so you give the insulin, the child does not eat, it will be a problem. So this is one place where you are justified to give a short acting even after the child eats, because if you are unsure with the amount of food the child is going to eat. Now coming to the long-term management, see there is a place for short acting plus basal insulin for injections, but nowadays people are using more and more. If you can afford, you can use insulin pumps, The advantage of insulin pumps is that you are instead of giving subcutaneously before each meal, you are putting a cannula into the subcutaneous space, and a small dose of insulin is continuously given. A short-acting insulin is continuously given round the clock. But the rate of speed of this insulin is titrated as per the formulas, because what you required is you had to give a basal dose, a very small dose, but with each meal you had to give a bolus dose also. The pump can give it. Then even the basal days will vary whether at what other day. Maybe a breakfast lunch will be one speed, lunch to dinner will be another speed and another rate, and the dinner to next day breakfast or night may be another rate. This is all calculated as per this one. The other thing is that you have to control the diet of these patients also, and nowadays the insulin requirement is more titrated with the carbohydrate content in the diet. And what is required nowadays, it is not called diabetic diet, it is called nutrition monitoring, and carbohydrate content is counted as per the patient can be educated to count how much of carbohydrate is there. It is called carb count, and depending upon the carb count you decide how much insulin to be given before a meal. You are going to eat the meal, the meal is in front of you, you can the patient can calculate the carbohydrate content, carb count, and decide how much it is, and depending upon that you can reduce you can decide how much of short acting insulin to be given to cover that meal. And usually the diet given contains about 50% of carbohydrate, 30% of fat and 20% of proteins, and a carb count usually you give around 45 to 50 grams of carbohydrate with the breakfast, with the lunch and supper, and in between you give around 25 to 30 grams of carbohydrate, and usually for about 15 grams 1 unit of insulin will be reasonable to cover it usually, but it may vary from depending upon the insulin resistance and all. So nutrition monitoring is very important, and especially carb counting in patients who are on short acting insulin in type 1 diabetes and also on insulin pump. Now coming to the type 2 diabetes management in the young, it is also another problem, because here the patient requires more of lifestyle changes rather than medications. But when the patient comes in the acute phase with hyperglycemia and with or without ketosis, you have to manage giving insulin and all those things. But once the patient is out of the acute phase of the emergency phase, and patient comes out and you have confirmed the diagnosis of type 2 diabetes in the young, then the treatment is usually based on lifestyle change plus drugs like metformin, which is the mainstay for the treatment, because insulin resistance is the main culprit in type 2 diabetes in young. So you give the patient metformin. You can start with 500 milligram twice daily, and usually they may require up to 2 grams, that is 2000 milligram per day. So with lifestyle changes, diet, exercise, you may be able to control it. If you cannot control that alone with that, then other drugs has to be used. One of the other drugs which can be used is thiazolidines, but they need to again put on weight, and if the patient is already obese, there may not be much place for thiazolidines if the youngster is very obese. The other thing, if you are not able to achieve a good diabetic control with metformin alone, there may be a place for DPP-4 inhibitors. If the patient is more than 15 years old, you can give DPP-4 inhibitors. Then the other thing is then to consider giving a long-acting insulin analog like glargine at bedtime plus daytime metformin. You may be able to manage a good number of patients. The other thing, if the postprandial hyperglycemia is a factor in these patients, there may be a place for giving alpha glucosidase inhibitor, adding on to the metformin therapy, so that the postprandial spikes can be controlled. So all said and done, type 2 diabetes managed in the young is mainly with metformin, lifestyle changes with metformin, and or other drugs like DPP-4 inhibitors or alpha glucosidase inhibitors, plus or minus requiring they may require basal insulin in the form of glargine insulin, one shot at night. And this is about but you may come across as time goes by very difficult to control diabetes and not following the diet properly and all. There you may have to go for a bolus insulin for covering the postprandial spike also. Then monitoring of diabetes. Both these type 1 and type 2 diabetic patients require monitoring. Monitoring for type 1 who is on basal bolus multiple dose of insulin, it is always better to do multiple dose fasting blood sugars and pre-meal blood sugars, or fasting blood sugar and postprandial blood sugars. So there are two ways you can play around. One is make sure you can do all the before 3 meals do a pre-meal blood sugars, and the pre-meal must be around 120, less than 120. Then you can say that you have achieved a good control. Or you do a fasting blood sugar and 2 hours after each meal, and make sure that it is in the range of 160, 170, 150, 170 range. That is one. So how often to do it? In type 1 diabetes, on multiple dose of insulin daily you have to do it. Whereas in type 2 you may recur once in 2 days or once in 3 days, depending upon how high is the. If the guy is only on metformin and control, weekly once is more than enough. So along with this monitoring blood sugar, the other monitor to be done is a 3 monthly hemoglobin A1C. This is very important because to know what is happening in the around the clock, and your aim target is supposed to be the gold standard for assessing the diabetic control. And in type 1 diabetes in children around 7 and 8 years old, you can keep the target a little high. It is very, if you get it less than 8, you must feel very happy. If a type 1 diabetes less than 10 years old, you are able to get a hemoglobin A1C of around about 8 or less, you must be happy. Whereas if it is 14 and 15 years old and all those things, you must aim to get a hemoglobin A1C of less than 7. So in type 2 diabetes, the young, because usually they are in the 14, 15, it is always a must that you must keep the target at around 7 below, have a good target. So this is about blood sugar monitoring, that is blood sugars and hemoglobin A1C. Now you have to manage the diabetes management include looking for the complications of long-term complications and taking necessary action. For example, all the diabetic patients, even if it is young, they must be monitored for renal function. They must be monitored for renal function at least a year, and after then they must be, the cholesterol must be checked once a year, especially after when they are more than 10 years old, and if they have got diabetes for more than 1 or 2 years. Monitoring of lipid profile, monitoring of blood sugar profile is a must. Then you must monitor even all type 1 diabetes patients, you must monitor yearly, at least yearly, for thyroid hormone function, because other autoimmune diseases like thyroid diseases can coexist or can manifest in a type 1 diabetes. So you must be looking for a autoimmune thyroid disease in a type 1 diabetic patients. At least if the anti-TPO is positive, you must check thyroid function every 6 months. If the anti-TPO is negative, you must do it thyroid function once a year in all the type 1. And also if the type 1 patient is having a loose stools and lauter, there must be other autoimmune disease like celiac disease has to be excluded by doing the proper antibody trial. The most important thing in managing diabetes in the child or adolescent is the psychological support which they require. You can imagine it is a disease where the patient alone is not the one which is involved, the whole family is involved in it. The moment when you see your 8-year-old child is having diabetes, you can imagine the psychological trauma which you and the patient may not be much aware about the long-term complications, but the parents are so much worried about it. So they require a lot of counseling and education regarding the disease. So the diabetes management in children especially is a team work, where the diabetologist along with the diabetic nurse, diabetic educator, nutrition specialist and psychologist have a big role to play in it. So after when they first know about it, they will be completely upset, knowing that the child has to be given injection throughout life. What will happen to my child? Will the child be able to study? Will he be able to get married, have a child? All this has to be sorted out slow one by one. And I am sure what we are seeing is that the day one or the first few weeks of making a diagnosis, the whole family is upside down. But you see them after 1 year or 1.5 years, when they have already learned the whole thing, they have accepted it as a part of their lifestyle to give injections and manage, and when they have met so many other people who are occupying well position in the society, their whole attitude change, and they will become good ambassadors for the new patients to give them the psychological support. That is what I find. And one more thing is that it is a team effort. So every member of the diabetic management team is very important. The educator, the diabetic nurse, the nutrition supporters, the psychologist. So it is a team effort, and that is going to pay you the dividend in the end. And the patient must be convinced, given examples how the type 1 diabetic patients taking multiple insulin have done very well in the society in the past, and quoting examples, you will be able to convince them and take away their worries and make them good diabetic patients. Lastly, before I wind up, the question comes, every disease has got a question. Prevention is better than cure. Can you prevent the diabetes in the young or the childhood diabetes and adolescents? For type 1 diabetes, there are so many studies going on giving to modulate the immunological system, trying to find out the people by doing the community assays of HLA systems and antibody titers of guard antibodies, and seeing who is going to get it, but they are all in the horizon, not going to be in the clinically practical in the immediate future for type 1 diabetes. For type 2 diabetes, I think prevention has got a big role to play. The moment the child is born onwards, if it is born to a diabetic mother, the chances the baby will be on the oversight side. The parents must be instructed about the possible complications or possible chance of getting a type 2 diabetes young because the child was born to a diabetic mother, like that, and take necessary action to see that the child do not get put on overweight. Make sure that the child's eating habits are tailored from the day one onwards, and make sure that the child is having a regular exercise and all those things. And with all these things, a good number of type 2 diabetes young patients can be prevented or at least postponed. The occurrence of the type 2 diabetes young can be postponed to a good length by proper action, by finding out the high risk group of patients in the families of diabetic couples, and giving the proper advice and bringing up them properly with the good medical nutrition therapy and all those things and exercise. You may be able to control this epidemic of type 2 diabetes of young. So thank you very much for hearing. Thank you.